All right, let's get straight into it. We're going to do a high-yield, rapid revision of HIV and AIDS, hitting all the key points you absolutely need to know for your MBBS exams.
So here's our game plan. We'll start with the virus itself, its structure, and how it spreads. Then we'll unpack how it attacks the body, look at the disease progression, figure out how we diagnose it, and finally cover treatment and prevention. And of course, we'll wrap up with some quick-fire revision points to lock it all in.
Okay, first things first. Let's get to know our opponent. What exactly is this virus, and how does it work?
So HIV, human immunodeficiency virus. The big thing to remember is that it's a retrovirus. Now, what does that mean? Well, most life works by going from DNA to RNA, but retroviruses are rebels. They work backward. HIV is an RNA virus, and it carries this special enzyme, reverse transcriptase, that lets it turn its RNA into DNA. This new viral DNA can then hijack our own cells. It's a really sneaky strategy. Okay, let's break down the virus's anatomy. Think of it like this. On the outside, you've got these glycoproteins, GP120 and GP41, which are like the keys the virus uses to get into our cells. The core, or capsid, is made of a protein called P24. Now, star this one in your notes, because P24 is a super important antigen we look for when we're diagnosing an infection. And then you have the 3 essential enzymes it needs to replicate. The mnemonic here is a lifesaver for exams. Just remember RIP, R for reverse transcriptase, I for integrase, and P for protease. These 3 are the virus's entire replication toolkit.
Now this is a classic exam question, so listen up. You need to know the difference between the highest risk of getting HIV and the most common way people get it. They are not the same thing. Look at blood transfusions. The risk is over 90%. That's incredibly high, but it only accounts for a small percentage of cases. The most common route, by a long shot, is sexual intercourse, making up a whopping 75% of cases worldwide, even though the risk per encounter is much lower. Don't mix those two up. All right, so we know what the virus is made of. Now, let's see exactly how it launches its attack and hijacks our immune system. Okay, so here's the blow-by-blow of the viral takeover. First, the virus's GP120 protein docks onto a CD4 receptor on one of our helper T cells. It's like finding the right keyhole. Then it fuses with the cell and injects its contents. Once inside, the magic, or, well, the terrible magic happens. Reverse transcriptase gets to work, turning viral RNA into DNA. But here's the really clever and devastating part. The enzyme integrase then literally stitches that viral DNA right into our cell's own genome. At that point, it's called a provirus, and it's game over for that cell. It's now a permanent, hidden HIV factory, and our body has no way of getting it out. So, we've seen the cellular attack. Now, what does this look like in a patient? Let's trace the clinical journey from the moment of infection all the way to AIDS. Without treatment, the natural course of HIV is pretty predictable. A few weeks after infection, you get this acute flu-like illness as the virus spreads like wildfire. Then, things go quiet. This is the clinical latency phase, and it can last for up to 10 years. The person feels totally fine. They're asymptomatic. But this is so deceptive, because during all those years, the virus is not dormant. It's hiding out in the lymph nodes, constantly replicating, and slowly, silently chipping away at the immune system. Until one day, the system collapses. Okay, here's a number you absolutely have to burn into your memory for exams. Less than 200. A CD4 T-cell count below 200 cells per microliter officially defines a diagnosis of AIDS. It doesn't matter if the patient feels okay or has other infections, that number is the line in the sand. It tells us the immune system is officially in critical failure. So, what if you can't get a CD4 count? This is where the WHO clinical staging comes in, and it's incredibly important in many parts of the world. It lets you estimate how advanced the disease is just by looking at the patient's symptoms. You go from stage 1, which is basically asymptomatic, all the way to stage 4, where you see these classic severe AIDS-defining illnesses like wasting syndrome or Kaposi sarcoma. It's a powerful clinical tool. So when the immune system gets weak, other infections see their chance to pounce. We call these opportunistic infections. Now, if you're asked for the single most common one worldwide, the answer is tuberculosis. TB is the #1 killer of people with HIV, so that's a huge point to remember. After that, you've got the other usual suspects. Fungal infections like PCP pneumonia and candidiasis, viral ones like CMV, and parasitic ones like toxoplasmosis. Okay, let's switch gears to diagnosis. How do we actually find this virus in the lab?
Here's another absolute classic for your exams: the window period. This is that tricky time right after someone gets infected, but before their body has made enough antibodies for our standard tests to pick them up. So how on earth do you diagnose someone then? The answer is simple, really. If you can't find the body's response to the virus, then you have to look for the virus itself. Instead of looking for the antibodies, we look for direct evidence of the invader. We can detect either the P24 antigen, remember that core protein, or we can detect the actual HIV RNA using a PCR test. These markers show up way before the antibodies do, closing that diagnostic window. The strategy for testing is a two-step dance. First, you screen. The goal of a screening test is to be super sensitive, to catch every single possible case. Think of it like casting a really wide net. You might catch a few things you don't want, some false positives, but you won't let any fish swim by. Then, for anyone who tests positive on the screen, you do a confirmatory test. This one is highly specific. Its job is to make sure what you caught is really HIV and not something else. It's how we get a definitive diagnosis. And when it comes to confirmation, what's the absolute best test we have? It's detecting the viral RNA with a test like RT-PCR. You'll hear about the Western blot, and that's a classic, but PCR is the true gold standard. It's the most sensitive and specific tool in the box, and it's the best way to diagnose an infection during that tricky window period. Now, for anyone studying or planning to practice in India, you have to know the NACO guidelines. These are really clever algorithms that tailor the testing strategy to the situation. It's not a one-size-fits-all approach. Are you screening blood for transfusions? One test is enough. Are you diagnosing someone who is asymptomatic? You'll need 3 different tests to be absolutely sure. It's a really practical, resource-aware system. All right, we've found the virus. Now what do we do about it? Let's get into management, both treating the infection and stopping its spread. The guiding principle for treatment today is beautifully simple and powerful: treat all. This is a huge change from the old days when we used to wait for the CD4 count to drop. Now, the moment someone is diagnosed with HIV, we start antiretroviral therapy, or ART. We do this for 2 big reasons. First, it keeps the person healthy, and second, it suppresses the virus so much that it becomes virtually impossible for them to transmit it to others. It's a win-win. So treatment isn't just one drug. It's what we call HAART, highly active antiretroviral therapy. The key is using a cocktail of at least 3 different drugs. Why? Because HIV mutates so fast that if you use only one drug, it will quickly develop resistance. By hitting it from multiple angles, we keep it under control. The go-to first-line combo for most adults in India under NACO guidelines is TLE, tenofovir, lamivudine, and efavirenz. Easy to remember. And of course, management isn't just about treatment, it's also about prevention. And we have a whole arsenal of tools here. There's post-exposure prophylaxis, or PEP. That's a 28-day course of drugs you take if you've had a high-risk exposure, like a needle stick. There's PPCT, which is a set of interventions that almost guarantees an HIV-positive mother can have an HIV-negative baby. And finally, we give prophylactic medicines to prevent those nasty opportunistic infections from ever taking hold. It's a multi-layered defense. Whew, we've covered a ton of ground. So let's wrap this up with a final, super condensed summary. This is the stuff you absolutely have to know cold for your exams. Okay, this is your final takeaway. Screenshot this, write it down, do whatever you need to do. Remember, it's an RNA retrovirus with a RIP enzymes. P24 is your key early antigen. The target cell is the CD4 T-helper cell. AIDS is defined by a CD4 count less than 200. In the window period, you look for P24 or HIV RNA. The gold standard test is RT-PCR. The treatment is HAART, and the guideline is treat all. The most common OI is TB. And finally, don't confuse the highest risk of transmission, blood transfusion, with the most common route, sexual contact. Got it? Now, here's a final thought to chew on. Given everything we know, why has creating an effective vaccine been so incredibly difficult? It's a great question, and it really gets to the heart of what makes HIV such a formidable opponent.